So the first speaker today is Professor Dr.S.MacNeil, who is a professor of tissue engineering at the Department of Material Science and Engineering at the University of Sheffield. She's academic lead of for the Biomaterials and Tissue Engineering Group based within the Croto Research Institute. And she is also currently the director of the Interdisciplinary Programs Office for the Faculty of Engineering. So the title of his presentation is Developing Tissue Engineering Materials for the Lab to the Clinic to the Commercialization. It's a really interesting talk. Please.
Thank you very much. Firstly, apologies for the delay. We decided to go with my laptop, and then we decided to change, and now we're back with my laptop. But there we go. Okay, so particular thanks to Professor Pitaresi for the invitation to be here. You'll be hearing from me twice in this workshop, which I think is excessive, but anyhow. I'm delighted to be back in Palermo. My husband tells me I did visit Palermo for about 3 hours once 10 years ago, but this time I will find the time to look at it properly. So I'm going to be talking about developing tissue engineering materials from the lab to the clinic to commercialization. And my group, can we put the lights down a little bit? My group has developed tissue-engineered skin, which you're going to be hearing about today for burns and chronic wounds, electrospun scaffolds, you'll be hearing about that tomorrow, and polymers that detect bacteria. That's much better, thank you. Now, what I've been working on really for perhaps the past 15 years is how to make tissue engineering that actually benefits patients. And the issue really isn't whether tissue-engineered skin can work. It's been used since the early 80s. So it is a reality. For patients with extensive full-thickness burns, the laboratory expansion of skin cells can actually be life-saving. But we also use tissue-engineered skin for patients with non-healing ulcers. But the challenge now, where we are now, is after nearly 30 years of culturing autologous and allogeneic keratinocytes for acute burns, injuries, and chronic ulcers, where are we? Well, it isn't the laboratory end that's really the problem. It's how to get skin therapy to benefit many patients. And this comes down to challenges which aren't so much scientific as practical and translational. How to deliver cells in a well-managed regulatory environment such that these therapies are clinically effective and economically viable. Now, I was listening to the introduction last night, and definitely it's interdisciplinary, and there's a whole lot of different pieces you need to bring together, and I think I'll try and illustrate that as I go through. Now, what I'm going to be talking about this morning is how to simplify the delivery of cells to wound beds. So we've developed 2D cell carriers for the delivery of keratinocytes, melanocytes, corneal epithelial cells, and more recently bone marrow MSC cells. A less exciting challenge, but a very real one, is how can we get the cells from the lab, the clean rooms, to the clinics? Now, very simple things affect this. The media choice, temperature, and pH. How can you transport cells from A to B? This is a big question for Europe, and one which we should be able to solve. So very quickly, people have been culturing skin cells since 1981, and they cultured keratinocytes for burns as cultured epidermal autografts, CEA. It's made commercially available through Genzyme in 1991, and 2010, small number of research groups and companies worldwide supplying autologous keratinocytes. And there isn't a real figure for this, but it might be many hundreds, it could be a few thousands of burns patients worldwide have been treated with cultured epithelial autografts. So very quickly how you do it, you take a small piece of skin from an unburnt area of the patient, separate epidermis from dermis, harvest the cells, pellet them, grow them into a little sheet of cells. Now these sheets of cells are very, very delicate, and to handle them we need to wrap them around some backing dressing. And there you have one sheet of keratinocytes ready to go to the clinic. Now let me just spend a minute explaining about this. The keratinocytes start off as colonies, and then they grow together until they join up, and they form a sheet that's 2 or 3 layers thick. Now, until that sheet is formed, you can't detach them. So the very first attempt to get these cells to the clinic was to make a pretend thin sheet of epidermal keratinocytes. And you can see how thin these are. So this production of cultured epithelial autografts requires the keratinocytes to grow together so it can be detached. The good thing about this is the methodology works really well. Using a feeder layer of murine cells and fetal calf serum for the mitogens, you get rapid growth of cells. We can culture cells from someone who's 80 as well as from someone from 2. So the methodology works well. But it's based on a 1975 method which contains man, mouse and cow reagents. If we tried to get that through regulators right now, we would fail. Now, a few slides showing the use of CEA in partial thickness burns. I've worked with the burns unit in Sheffield since 1992, and this little girl, partial thickness burns, we put something like 20 sheets of cells onto her legs, and that's the appearance a month later, and that just filled in quite nicely. Now, the problem for burns is with full thickness burns, where you've lost all of the epidermis and all of the dermis. What surgeons will always do is take a skin graft from elsewhere on the body and put it in place. And that is the gold standard treatment, and we're not seeking to replace that. However, if you have a patient with very extensive burns, there isn't enough unaffected skin to do that. And what burn surgeons do is they replace the dermis with one material, something like Integra, and then they may wait to go back to the initial area, take another skin graft and put it in place, or we put cultured cells on top of it. So this is a patient handled in this way. Full thickness burns, stripped right down to the muscle, and then cadaveric skin used to provide the dermis and his own cultured cells on top. Now this is called the Kuno technique after Professor Charles Kuno in the States who developed this. So these are the patient's autologous keratinocytes and someone else's donor cadaveric dermis. And although this is not pretty, this is judged a clinical success as there was no further grafting required on both legs. Now, after many years of doing this, we did a 10-year audit, and I don't expect you to read this, this is just to remind me. We looked at many patients with extensive burns, 40 to 80% burns. Some of those patients received donor skin to provide a dermis, some did not. And the black histograms are unfortunately the patients that died. And the little numbers at the top are where we put cultured sheets of cells on top of them. Now, from doing this study and this audit, we learned a lot of things. We learned things that people already knew. These sheets are very fragile and hard to handle. And their overall take rate on the patient was less than 50%. And that turned out to be very interesting. It wasn't to do with the quality of the cells leaving the lab. It was all to do with the wound bed onto which you placed the cells. But the thing that was most interesting was very embarrassing. Over half of all of the sheets of cells we produced in the lab ended up in the bin, in the bleach plot. They did not get to the patient. And when we analysed that, it was because of the timing. Now, for those sheets of cells to come together and form a sheet, it takes them at least 9 days. So you have to wait, and then you can detach them. But the cells continue differentiating. And if you don't use them within 3 days, they differentiate so far they don't attach to the wound bed. So your actual shelf life is between 9 and 12 days. This is very, very unforgiving when you're trying to match this to a badly burned patient. And so you make a plan to grow these cells for a particular patient, and then something happens. The patient has an infection, they can't go to theatre, the surgery is put back, the surgeons ring you and say, Sheila, we don't want those cells on Friday, can you give us them next Friday? And I had to say no, because all of the cells were already in culture for this and too differentiated. We couldn't change the patients. We clearly needed to change how we got the cells from the lab to the patient. So we did what I would call as very, very simple, dumbed down tissue engineering. We made a little post-it note for delivering the cells to the clinic. And I'm going to tell you all about how we did this. So we used plasma polymerization technology. We put the subconfluent keratinocytes on this, and we delivered them to the patient, burns patients and chronic patients. So it started with my colleague, Professor Tony Ryan, and he wanted me to grow cells for him on television. And anybody who's cultured cells, it's not that exciting. So what we did do is we took a small biopsy from his bottom, we grew the cells, and we made a template of his name. And within the template, we put down acrylic acid. And outside of the template, we put down octadiene. And then the cells went to where the acrylic acid was, and they left the octadiene. And this turned out to be an excellent teaching slide. So this just shows you that you can make a surface that cells like to attach to, and you can make a surface that they don't want to attach to. So the real work we did is more boring and very classical. We looked at acids, amines and alcohols, and asked which ones would keratinocytes like to attach to. Well, they like acid functionalized surfaces. They actually liked them so much that the first surfaces we made, the keratinocytes would not come off the surface and go onto the wound bed. So we had to go around the loop again and make this surface unstable. So it's a little bit like the sort of post-it notes that we use to stick on things and then peel off. So this is sticky, but not too sticky. So the cells would leave the carrier surface and transfer to the wound bed. And we commercialized this. Once we'd got this working clinically, we set up a spin-out company, which I'll tell you a bit more about, and we called it MySkin, because this is always autologous. It's the patient's own cells. So it's a cell delivery surface for keratinocytes. That was our initial plasma rig. We've got a much fancier one in the company, very small clean room, put the cells onto the carrier disc, and then my two colleagues, Ning Wen Zhu, took them to burns patients, and Manar Mustafa took them to patients with chronic wounds. Now, this is how the MySkin process works in terms of the timeline. The surgeon will ring up the company. Let's say we'll go with burns, first of all. We will take a small split-thickness skin biopsy and take it to the company. The cells are expanded. They're expanded exactly as they used to be, but we don't grow them into sheets. We just wait till we have plenty. Very often, for chronic wounds, we do a massive cell expansion and freeze most of them in liquid nitrogen. And then for chronic wounds, we bring them up once a week, put them on a carrier, and deliver to the patient. So for chronic wounds, we might deliver to the patient over 6 weeks until the wound is healed. For burns, it differs in that we do a massive expansion and we deliver a lot of cells to the burn patient as soon as possible, maybe at 2 or 3 weeks, and then a second wave a few weeks later. So burns. So here we have delivered cells over wide-meshed autograft onto a patient with full-thickness burns. And this is the appearance 10 or 12 days later. Now, the backing dressing is medical-grade silicone. Cells will not attach to this. Onto this, we plasma polymerize a very thin layer of acrylic acid. The cells love attaching to this. But if you put them onto this wound bed, they will transfer. And you might just about see the curvature of where cells have left these circles and gone onto the wound bed. The surgeons then started to use the MySkin in ways we hadn't thought of. That's always a good sign when the surgeons start to do things that you hadn't thought of. So they started to use these discs to heal up donor sites. Burn surgeons often have to wait until a donor site will heal, and they'll come back and take another skin graft. And this time, this was only 3 days after putting the cells on. Now this, from our point of view, is brilliant because this is a perfect wound bed. No infection, no trauma, cleanly made, and cells leave the carriers, go onto the wound bed, and we have that is almost completely epithelialized. In another couple of days, you could take another skin graft. And then the burn surgeon started to say, well, can you use these cells on patients where skin grafts have failed? Now, this patient, and I'm going to show you a video, it was the video that caused all the problems, so I really hope it works this time. This elderly gentleman had lost the skin off both legs. Now, not a major problem for burn surgeons because they were able to take skin from his back and graft. But he was elderly and the grafts failed. And now you have a problem. As they can't take more grafts, it won't happen. So we started to put cultured cells on, and that leg we got completely healed after 12 applications, which we did on an outpatient basis. And this leg we improved to that point so that they then did do a skin graft. And that was 2 months after treatment.
The living bandage won't completely replace the need for traditional skin grafts, but for patients with severe or extensive burns and those with wounds that just won't heal, this technology could offer a second skin.
It's quite fantastic really to what has been achieved by the treatment. I was warned old people, skin graft doesn't always take, and very often gangrene and amputation follows. So I was very, very pleased. The recovery came so quickly.
It costs over £1,000 to treat a patient with living bandages, but a cure for damaged skin means a return to normal life. And for Archie, that's priceless.
Now, the very good thing about Archie was a wonderful patient. He was 80 years old. We were able to discharge him home, and he came in once a week to have the cells put on, so he didn't have to spend months in hospital. Now, the burn surgeons then said, okay, how about these patients? So this patient was an elderly lady. She had a broken leg. She was in hospital about to be discharged, and then she had a gash to the tibia. And this often happens, just didn't heal. And so we put cells on her, and that was after 4 applications of cells. After 6, it was completely healed. And we're able to put on those cells on a ward without anesthetics. Very, very simple. We then started working with diabetic ulcers. Now, this patient had this ulcer, and it had not healed in 3 years of attending a specialist diabetic foot ulcer clinic. Now, I had to learn a lot about diabetic ulcers because I knew about burns. But these ulcers, the patient feels no pain, so they walk on it. The blood supply is appalling, so it doesn't heal. But after 8 applications of cells delivered in the dressing clinic, we got that ulcer healed. And then, some years later, we managed to publish a single-blind study. 18 patients, we assigned all the patients to treated or placebo groups, 3 cities, 4 diabetic centers. All the patients had 6 weeks with a carrier, but they didn't know if they had cells or not. They then had another 6 weeks with cells, so all patients had some benefit. And the study showed that the carrier dressing alone didn't heal the ulcers, but the carrier dressing plus cells healed or reduced ulcers in 70% of the patients. And I'll just show you one example here. This is a patient with an ulcer on the heel. We followed that for 4 weeks, wasn't healing up. After the end of 6 weeks of the carrier but no cells, the placebo, no healing. At the end of 6 weeks with the cells, it's healed, and 3 months later. Now, okay, these ulcers are very polite ulcers. They're not infected. This is the other side of diabetes. If you're squeamish, you might not want to look at the next few slides. So this patient presented to colleagues in Manchester, diabetic foot, untreated, unmanaged, and the toes were amputated initially. And the wound bed is a mess. That is not going to heal. They were thinking they were going to have to amputate this poor lady's foot. What they did is they used larval maggot therapy to clean up the wound bed. They used vacuum-assisted therapy to improve the wound bed, but you can see the edges of this wound. It's forgotten how to heal. And then they asked us if we could culture cells, which we did. While we were doing that, they put honey on as an antimicrobial, and there you see us putting the discs of cells on. And this was the appearance of the foot after 2 applications of my skin. So we only did 2 applications. We didn't need any more, because you can see what's happening now. There's re-epithelialization from the edges. So they were able to save what was left of that lady's foot, so she was able to be weight-bearing with a special shoe. Now, is commercialization of tissue engineering easy? No. I'm going to summarize 7 or 8 years of pain in one slide. When we had this working, we formed a spin-out company to commercialize it and make it into a product. And we formed the company in 2000. The company was called Celtran. Our first product, My Skin, began making a small revenue in the NHS in 2005. But our company ran out of money. Although we were earning a small amount of money, it wasn't enough for our board of directors and our investors. So the company folded in 2007, the same week that we got approval for a second product, freezer-ready donor keratinocytes, to be approved for clinical use. The products, My Skin and CryoSkin, got acquired by another company in 2008. Now, in the UK at this time, this was a really, really bad time for investment in small companies. That company folded 1 year later. The products were then acquired by another company, Ultrica, in October 2009. And Ultrica's been supplying My Skin to NHS in Europe since 2009. And when I last talked to them a while ago, they were looking to obtain a license to deliver in Europe, but I don't know if that's happening or not. So the products exist. The products are on their 3rd company. There's a lot of pain behind that. I'm pleased we've got the products out there. Right, so going back to the science, how can you get cells to the clinic? Well, cultured epithelial autografts, it's been in use since 1982. It's technically demanding for the lab, and there are timing difficulties, as I've explained. I'll go to this one, spray-on cells. You can culture the keratinocytes and spray them on. That can work well if the cell culture lab is close to the patients. It's technically simple for the lab, but it requires skill and use for the surgeon. And there are real problems in transporting cells for more than a few hours. Cells need to know where they are. They have integrin receptors, and if they can't attach, they're not going to be happy a few hours later. Cells on a carrier, we developed these because it's easy to handle for the lab, it's easy to handle for the surgeon. We've dumbed it down. This is simple tissue engineering. It also aids the transport of cells, as I'll show to you, and it gives us back our flexibility of timing. So what determines how well the cells do? Well, after many years of doing it, these were the conclusions I came to. The health of the keratinocyte, everything you've done in the lab, probably only accounts for 20% of your success. The nature of the wound bed, and to a lesser extent wound bed management, probably account to 80% of the success. So this is the difficult area. Now, while we were developing the first one, BiSkin for delivering keratinocytes, we went on to use the same technology for other cells. So we made a surface for keratinocytes and melanocytes for treating patients with vitiligo. We used a coated contact lens for delivering corneal cells to the cornea. And more recently, we've just finished a surface for delivering bone marrow cells for chronic wound healing. None of these are yet in the clinic. So for vitiligo, and I can speed up because it's the same technology, so it's well known that you can culture cells from the pigmented area and put them back on the non-pigmented area, and you can get good results once the vitiligo is stable. So we used our tissue-engineered skin model, more on that tomorrow, and we demonstrated that we could get pigmentation within this. We made a carrier that keratinocytes and melanocytes were happy to be on. We showed that the cells would transfer to the skin model, and then we let these grow. So this skin model is human dermis, and this is 10 days. So the keratinocytes we've transferred have made a well-attached epidermal layer. The melanocytes are here. The melanocytes end up where they should. They know where to go. We don't have to do anything fancy to tell them, and they retain the ability to pigment. So we're able to assess that the cells that we're transferring still know how to act as professional pigment cells after transfer. Going on rapidly to the cornea, same logic, and I'll be talking more about cornea later, and not today. So scarring of the cornea, could we actually coat a contact lens to deliver the right cells? So we did a lot of work with different surfaces, the idea being that we would find the right plasma polymerization strategy to put inside a contact lens, put the cells on it, and then transfer to the cornea. So a lot of classical structure activity work, acrylic acid, alcohol, allylamine, finding out which surfaces corneal epithelial cells like the keratinocytes, they're like acrylic acid. We then took a commercial contact lens. Now, as all lens wearers know, these are already treated so that they don't bind protein, ideally, unless they get really dirty. So this is our uncoated contact lens, and cells don't attach to it. We then put acrylic acid onto the inside of a contact lens, which sounds crazy, but now the epithelial cells will grow on it. We used a rabbit corneal organ culture, so we obtained the rabbit eyes from a food company. The rest of the rabbit went into pet food manufacture, and we deliberately wound all of this. So that's a rabbit cornea, unwounded, there's the epithelium. Here we've removed all the epithelium. And now what we do is we transfer corneal cells off the contact lens onto it, and that's after 6 days. You can see there's some cells there, but they don't look very good. You leave them alone, and after 14 days, you've got a multi-layer. It's not very organized, but clearly these cells are very proliferative. Now, more recently, we've been looking at a carrier for delivering bone marrow MSC cells and fat-derived MSC cells. Now, this is an EU consortium, which is finished now, called Cascade. It consisted of blood banks, so France, Germany, Italy, and the UK working together. Now, adult bone marrow cells are very attractive. They're slightly immunosuppressive, and they can stimulate wound healing and angiogenesis. Now, this offers the possibility of using banked allogeneic cells for wound healing. And we work very closely with Professor Suzanne Watt of the National Blood Services, Oxford, in doing this. So exactly the same. We did a plasma polymerized surface with acrylic acid, and this is just XPS analysis of it, showing that we've got the surface we think. Now, MSC cells, they're very useful, but you have to do a lot of work to prove you've got MSC cells. So you can characterize the MSC cells in terms of which antigens they do have and which antigens they don't have. So Suzanne's lab did that, established that these were bone marrow-derived MSC cells. Then the next question is, once you put them on the carrier, will they still be MSC cells? So these are MSC cells on tissue culture plastic, and these are the MSC cells on our acrylic acid carrier for 3 days. And you don't need to look at this lot, they are identical. So they retain all the same antigens after 3 days on the carrier. Will they grow on the surface? And yes, they do grow on the surface. The results are from day 1 to day 7, so they're increasing number on the surface. Okay, if they're so happy on the surface, will they leave it? So again, these are the cells on the carrier, and we put them onto the human dermis. So we showed that they transferred from the carrier onto human dermis. We just stained them all with MTT. And we looked at how many cells remained on the carrier after 24 hours, that's the black, and how many cells were on the human dermis. And this is the results after 24 hours, 72 hours, 7 days. And we can keep them on the carrier for at least 3 days. Now, 3 days is important. I'll explain why. Will the cells that leave the carrier attach to the skin? So we used GFP labeled cells, which Suzanne provided us, and we're able to look at the transfer of these cells onto the human dermis, and they stay pretty much near the top, and we could look at their depth penetration. They really just hung around the top of the skin, but they attached quite happily. So the next question, are they still capable of doing anything useful? So one of the things that MSC cells do, they support endothelial cell progenitor cells to make early stage blood vessels. So an assay that can be done is to look at how the MSC and the EPC form little tubules. Now this is very tedious, painstaking work, which Suzanne's postdoc did. And basically these were cells that were on tissue culture plastic, and these were cells that were on the carrier for 24 hours and for 72 hours. And the results showed that even after 72 hours on the carrier, they still had the ability to help these endothelial cell progenitors make little tubules, which are sort of proto blood vessels, early stage. Now, back to the big picture. You've done something you're proud of, but how are you going to get it to the patients? So this is how my skin travels. So from a lab in Sheffield, a biopsy is taken and sent to the lab. In the clean room, it's expanded up, put onto the carriers, and then shipped back to patients in the UK. And we have, while the company was running, been able to deliver cells throughout the UK. So, a few years ago, it was thought that every hospital would establish a clean room for culture. But that isn't going to happen. It's too expensive. Not just the clean room, but the staff. So the simpler thing is do your cell culture in one place and then transport the biopsy to it and transport the cells or tissues back. More problematic is reimbursement for these procedures. So transport, when you begin, cells are hand-delivered lovingly. So Ning Wen and Manar would take the cells to the patient, put them on, report back to us, all fine. When you deliver to many patients across a city, you need to use commercial carriers, FedEx or DHL. Now, the next few slides are tedious and useful. I'm only going to go through quickly. We basically asked, can we transport these cells? And we did it by looking at keratinocytes and melanocytes on the surfaces. We looked at them in different media. We looked at them at different temperatures, 37, 23, and 23 with extra CO2. And I'm only going to go to these 2 slides to give you the bottom line. Temperature affected transport. So we cultured them for 48 hours on a media that had agar but no fetal calf serum, and we looked at their ability to transfer onto the human dermis. And you can see that that's not bad, that's very poor. The very poor one was at 23 degrees. The very good one was at 23 degrees with extra CO2. Cells do best at 23 degrees with CO2 gassing. So I'll just take your eye straight to this. These are the cells that remained on the carrier. These are the cells that transferred to the dermis after 3 days transport at 23 degrees with extra CO2. I just need to take you to this bottom one. Here, this is histology of the keratinocytes and the melanocytes on skin. And you can see this looks very poor and disorganized, poor and disorganized. This one decent epithelium, decent melanocytes. So these results were obtained by transporting the cells at 23 degrees in CO2. So how you transport your cells makes a big difference to the performance of the cells when they reach the other end. So this can be summarized very simply. We got most melanocytes in the correct place when the cells were transported at 23 degrees with CO2 gassing. So to finish, we have simplified the delivery of cells from the lab to the patient by developing an engineered surface based on plasma polymerized acrylic acid for the delivery and transfer of laboratory expanded keratinocytes to patients. We've got this product, MySkin, in use for acute burns and chronic ulcers, and it's been commercially available in the UK since 2005 to the present time. Not yet in the clinic, we've developed a similar approach to delivery of keratinocytes and melanocytes for treatment of vitiligo. We've produced a coated contact lens for delivery of cells to the cornea, and we've very recently completed the development of a carrier for bone marrow cells. Ultimately, we'd like to use these for chronic non-healing wounds. Transport conditions. MySkin travels at around 20 degrees in an insulated box with cells on agar media. Now, why is 3 days important? Well, we aim to deliver the cells in 24 hours, but things go wrong. Operations get delayed, clinics get cancelled, but the cells are good for at least 2 days, and everything I'm doing right now is trying to get 3 days out of everything. Our recent research with carrier conditions shows temperature and CO2 pre-gassing helps extend the functional life of the cells, as assessed by their performance on tissue-engineered skin models some 3 days later. Now, this is an area of opportunity for people working on polymers. As yet, there's very little published work on transport conditions for cells. It will be enormously important in making cell therapy accessible to a large number of patients. Cells, adherent cells, need to travel under conditions where they know which way is up. They need to be attached. There are polymers that can actually extend the shelf life of the cells. So to conclude, it's going to take concerted efforts to bring it all together. And we're looking at a future where there'll be a small number of clean rooms specialized in cell therapies, which will hopefully be able to deliver cells to a large number of patients across Europe. Practical issues of how to put cells on carriers and how to transport cells and in vitro quality assurance are all being tackled. Many of these are not rocket science. They just require hard work. They should all be achieved. And we need concerted efforts with respect to establishing clinical studies to show the benefit of therapies and to work together on regulatory issues and to involve companies in translating research to commercial reality. And I'm just going to acknowledge all of the people who funded this work over the years and the group that actually do the work. Thank you very much.
Thank you, Professor MacNeil, for the really extremely interesting presentation. And now the presentation is open for discussion. Are there some questions from the audience?
Excellent presentation.
Thank you.
Very interesting. I think a curiosity concerning the cost of sort of an idea of, for example,
Sure, yeah. And it is an idea, because I'm no longer with the company that worked with it, but when we first commercialized it, cell therapy for chronic wounds would probably cost something like £4,000. Now that would be, choosing the patients is critical. If the patient responds to conventional therapy, don't go near expensive tissue engineering. If the patient is not responding to conventional therapy, then that £4,000 would be taking the biopsy, culturing up the cells, and delivering at least 6 lots of cells back to the patient. Burns, depending on the size of the burn, it can be 10,000, 20,000, it can be major, but it can also be life-saving.
Okay. Other questions? Professor Fresta? Microphone.
Thank you.
You're able, okay, with the microphone. Fine. Just how many questions? May I put just 2 questions? Yeah, thank you. Just the first one, concerning your presentation and the slide of ulcer, diabetic ulcer. In that case, is necessary just to remove the collagen formation just on the neighborhood of the wound, or you direct treat with your MySkin film This is the first question. Secondly, I have just to beg your pardon because I'm not an expert concerning tissue engineering. Part of my group work on cancer. One of the main points in cancer treatment is, just to destroy stem cells. But under your point of view, I suppose the stem cells can be really an intriguing and maybe a focus point just to look at. And at the very end, just concerning...
That's three.
Right? Just at the very end, if you can suggest, if I would like, let me say, to start on working on tissue engineering, at what parameters I have just to look at to have a performing scaffold for, let me say, a tissue engineering?
Okay, I think the third question, quite honestly, is better done over coffee because that's a very big one.
Fine.
But the first two, very happy to. Okay, because of speed, I didn't really describe how we treated the diabetic ulcer patients. A general point is if you make a therapy which requires clinicians to make a change in how they do things, it won't get adopted. So what we did is we made our therapy fit in with exactly how the wounds are currently treated. So best practice for treating those wounds is to make sure they're clean, debride them. Yeah. The ideal procedure is called sharp debridement. You take away everything that's... Now at that point, they would remove everything and then just bandage it conventionally and the patient would leave. So at the point before they bandage, at that point we just put on the disc of cells and then bandage it. But you're absolutely right, you need to remove the dead tissue or you won't get healing. Absolutely, yeah. The second thing about cancer therapy and stem cells, more and more people are finding bone marrow stem cells or fat-derived MSC cells to be really, really useful. So there's a very good argument, possibly, a very good discussion to be had here, and maybe before you do a lethal irradiation, to actually maybe harvest some of those cells from patients' fat. Women such as myself, we have plenty of fat. Most people, no, but you can harvest from bone marrow, which is painful, or from fat, and then maybe store them, because I think their ability for wound healing, we're only just beginning with those. Thank you. Absolutely.
Okay. We have another question.
Just a short question. You talked about the development of these carrier for cells and the treatment with plasma of acrylic acid. So the surface is acrylic acid or something polymerized.
Yes.
But the substrate, maybe I didn't catch.
No.
You change the substrate or it's always the same?
It's always been the same for these. So we've used, for everything I've presented today, it was just a medical grade silicone that could go on a wound bed, you could see through it. Now the technique of plasma polymerization, you can put it on other surfaces. We can put it on scaffolds that are biodegradable. It all really depends on what your application. Yeah.
In this case, it's always...
Yes.
We have another question. The mic. Sorry. This way.
Now, could you say that my skin for the delivery of other cells, for example, fibroblasts, that in recent account that those are very different.
Yes, the MySkin approach can be used to deliver fibroblasts or keratinocytes or melanocytes or corneal epithelial cells. We ourselves have not used it to deliver fibroblasts, but it could be. The challenge of how to produce something that's got both an epidermis and a dermis, I'm going to go into tomorrow. So everything I've described today is just about delivering a layer of epithelial cells.
Okay. We have another question here.
Just rapidly to come back to the former questions about plasma technology, which is the base of your technology. I just would like to know about the upscaling of the polymerization, because you work on quite small samples, I think, in terms of surface. Is it upscalable to larger sheets of silicone?
Absolutely is. When we started this, we did it with a very small experimental rig, which I showed you, and the company has got a bigger rig, so it can produce something like 80 sheets at one time. You can produce bigger pieces. You can produce different shapes. Every surgeon you talk to wants a different shape. So as a small company, we just made a 6-centimeter disc, but the company is now making 10-centimeter squares. You can make it very much bigger. The practical issues then are the culture, fitting it in with the culture plastics.
Okay. If there are no other questions, I think we can move on with the schedule. And please join me to thank again Professor MacNeil for the nice presentation.